Welcome everyone to this AAAPC webinar. My name is Dr. Liz Sturgis. I'm a GP researcher at Monash University in Australia, and I'm the Vice President of AAAPC. To begin, I'd like to acknowledge that many of us are joining from colonised lands, and I'd like to pay acknowledgement to the Ngunnawal and Ngambri people whose lands I'm joining you from today, and pay my respects to their elders past, present and emerging, and a warm welcome to First Nations people joining us from around the world today. To get started tonight, we'd just like you to know a little bit more about AAAPC, and I'm lucky to be joined by the chair of our Committee on Membership, Dr. Laura-Lee Richard, who's joining us from New Zealand.
Kia Liz. Kia koutou katoa. Greetings everyone. My name is Laura-Lee Richard. I'm a Senior Research Fellow at the Department of General Practice and Rural Health at the University of Otago in New Zealand. As Liz mentioned, I'm Chair of the Membership and Marketing Subcommittee for AAAPC. And I'd just like to say a few words and also invite you to join our vibrant and disciplinary diverse community. So AAAPC stands for Australasian Association for Academic Primary Care. We're a leading advocate for high quality multidisciplinary primary care research, education, policy and practice in Australasia. We are comprised of members from academia, but also higher degree students and postgraduate trainees of primary care disciplines, and a range of other organizations, including regional health authorities, primary care training providers, and professional colleges with a connection with primary care. AAAPC's strategic goals include increasing linkages within and across primary care networks, promoting and nurturing research and scholarly activity in primary care, promoting excellence in primary care education, and also championing a vision of primary care that's underpinned by strong evidence and strong education. So when you join AAAPC, you can benefit from a range of things, including accessing resources and events, such as this event tonight, so research webinars and mentorship programs. You benefit from building relationships and networks with leaders from within international primary care as well. You can apply for member-only grants and scholarships to attend and present at primary care conferences, and you can also contribute to lobbying efforts to influence policies and decisions that affect Australian, New Zealand, but also the broader international primary care community. So you've got plenty of opportunities to get involved with AAAPC. We've got 4 very active subcommittees, namely academic policy and advocacy, early career researcher and capacity development. We've got the conference subcommittee and the famous membership and marketing subcommittee. So to join us, you go online, you visit our website, aapc.org.au, you go under join us and membership. Back to you, Liz. Kia ora.
Thank you so much, Laura-Lee. That's a great overview of the organisation, of which we're all very proud. Tonight, we are absolutely delighted to welcome Professor Carl May from the UK, who's agreed to join us and share his knowledge with us. To interact this evening, I feel like I live my life on Zoom, but in case you are lucky to not live your life on Zoom, there is a Q&A box at the bottom of your screen. If you hover over that, if you'd like to ask a question of Carl, you can pop the question in there while he's speaking. And at the end, we'll have a lovely Q&A session, and Laura-Lee and I will put your questions to Professor May. So please don't be shy. There is also the chat box if you'd like to talk to other attendees, and that's just for more informal chat. We'll be watching the Q&A box for questions for the panel. So before we'll get right into it, Carl, I'd like to really welcome you to talk today on when implementation goes wrong, how we can understand the dynamics of failure to launch. And so Professor Carl May is a medical sociologist and implementation scientist. I know for myself, his work has really influenced my own research from when I first heard about normalisation process theory at the Australian PICRIS conference. And I've continued to work with that theory in my own work. So it's my absolute pleasure to meet you tonight, Professor May, and hear you speak. So I'd like to pass over to you now for your talk, and we'll have the panel at the end, and Laura-Lee and I will join you back there again. Thank you very much again.
Well, good morning, everybody. It's a common problem, I think, for people interested in implementing new technologies that, as you can just see, some of us can't use them. I want to start with just saying thank you very much for this invitation. It's great to be able to talk to people all around the world without having to spend 2 days on an aeroplane. I think many of you know the very warm kind of feelings that I have towards primary care in Australia and New Zealand, and how much I've enjoyed working with some of you. And I just had a quick look through the participants list, and I was just so pleased to see some really nice old friends who had thought it was worth listening to me again. Lovely to see you all, and lovely to see so many people I don't know. So a few words about me to begin. I'm a sociologist, and I became interested in implementation entirely by accident. All of the best career moves are accidental, and I became interested in implementation because I got asked by my friend Francis May to help on a telemedicine project in the mid-1990s. I was asked on the basis, if I recall the email correctly, because I knew how to use a video camera. And from that, I became interested in why telemedicine systems were so difficult to adopt and incorporate into routine practice, not just in the UK, but everywhere. And so everything that I'm talking about this morning stems from that one moment, that one email, because I became really, really interested in how socio-technical transformations in healthcare occur. And I became interested in the kinds of empirical and theoretical models that we can employ to understand them. And acknowledgements are important. And my partner in crime in a lot of the work that I'm talking about this morning is Tracy Finch. Tracy and I have worked together since 1999. When she joined my group in Manchester as a postdoc, and we've had this wonderful research partnership ever since. She's responsible for really developing NPT as something that where the constructs of the theory are amenable to measurement. She really pushed me in that direction right from the very beginning. Many people have funded this work. I'm grateful to them all. So there are 3 parts to what I'm going to do today. I'm going to talk about, well, what do we know about how implementation processes work? And I'm going to do that through the lens of normalisation process theory, which is the work that I, Tracy, and many others have sort of developed as a way of explaining the factors that motivate and shape implementation. And then the main bulk of what I'm going to do is talking about the problem of failure to launch. Why can't implementation projects sometimes get off the ground? And I'm going to do that through the lens of NPT, and I'm going to present 4 anonymized composite case studies. So these are not individual studies, they're collections of aspects of projects that I've reviewed in an earlier systematic review. And finally, I'm going to say a few words about what's essentially normalization process analysis. What can we do to think about how things might go wrong, and what can we do to predict some of those outcomes? So that's quite a lot to get through in half an hour, but I'm going to do my best. So let's start with, well, introducing normalization process theory. And I'm going to start by saying, well, implementation science drives particular kinds of studies. It drives big trials. It drives carefully worked out feasibility studies. And it drives attempts to push evidence-based interventions, high quality clinical knowledge from the domain of experimental clinics and experimental clinical work into real world. So it's about crossing the third translational gap in an effective way. And implementation science kind of has become quite a lot like other areas of medically oriented research. You know, it's a bit like health technology assessment. It's a bit like quality improvement work. It's become organized around large trials. There is a problem here. The purpose of a large trial is to understand causal processes, but also to eliminate confounders. And as Jeffrey Braithwaite has kind of made it very clear in recent work, eliminating confounders in a healthcare system is possibly a lost cause. So, you know, what Braithwaite tells us is that we're actually looking at complex adaptive systems that are highly dynamic, very emergent, and by that means they unfold over time in not necessarily predictable ways. And also they're complicated as well as complex. There are lots of moving parts. There are lots of agents and actors. And there are lots of what Penelope Hoare has called events in systems. There are kind of things that are going wrong that are nothing to do with what we're looking at now, and big exogenous events that interrupt and disrupt healthcare processes. And we're living through several of those right now. So normalization process theory started by saying, where's the routine incorporation into practice? But slowly it's become a way of characterizing mechanisms of self-organization and adaptation in complex adaptive systems. And that's really important when we kind of start to look at what real-world implementation pathways are like. They are also adaptive and emergent. They begin with the strategic intentions of groups of actors, consensuses about what must be done, about how to do things, and adoption decisions that are sometimes not necessarily evidence-based. And then there are processes of adaptive execution and negotiations about capability and context that don't necessarily lead to even and unproblematic routinization or normalization into practice. They can lead to tremendous variations between and within settings and over time. Practices that, or bodies of practices that are incorporated into everyday work don't last forever. They become obsolete. They suffer entropy. They die and decay. That itself is a topic of great interest to implementation researchers. You know, how do you de-implement things? A lot of the time, though, we don't have to worry about de-implementing things because actually implementing them is difficult enough. So what does implementation mean? Well, the view that we have taken is that implementation is the translation of the strategic intentions of one group of actors into the everyday practices of others. And what that does is it says implementation processes are like other kinds of socio-technical transformations. But what it also draws our attention to is that the essence of implementation is collective action and collaborative work that can be made visible. Implementation is always about the things that people do, and we do things often that we don't want to do, or that we don't think are going to work. Our lives are full of having to do things. So our intentions and our beliefs and behaviours are sometimes not as closely linked as we might like to think they are. But basically, sometimes we have to do things because it's part of our collective project. It's part of our collaborative work. And normalisation process theory is all about the work. It's about what people do as they engage with new activities, with innovations, and about what mechanisms motivate and shape the operationalization of those practices, and how they become embedded in everyday life, and how that embeddedness is then sustained. So when I'm sort of thinking about NPT like this, it's like a lot of theories in the social sciences. It's quite abstract, it's quite context independent, and that's actually what a theory should be like. It's an important feature of a theory that it's abstract. But everything that I'm going to talk about theoretically this morning, or this afternoon, or this evening where you are, is about a theoretical project that is completely empirically grounded. There is no philosophical speculation here. What we're discussing are things that have been observed to happen in real life, and that have gone through a process of iterative analysis, and most importantly, for any kind of theoretical position, they've been independently tested by other researchers. Some very important studies, for example, John Furler's work about implementing insulin in type 2 diabetes in Melbourne, and Lisa Hooker and Angela Taft's MOVE trial. There's some pretty wonderful work in Australia using these kinds of theoretical propositions. The theory helps us understand three things: the properties or qualities of an intervention itself, the actions of participants in implementation processes, the things that they do, and how they work together in contexts. And it's those three levels of analysis that I find attractive and interesting about employing theories like this to explain and understand implementation processes. So let's think about the problem of failure to launch. And all of this comes from, we did a lot of work about telemedicine at the end of the 90s, beginning of the noughties. And I was interviewing this guy who was an emergency department doctor. He's become very eminent in his field subsequently. And we were talking about telemedicine. He said, Carl, he said, I don't know why you're interested in this. The trouble with telemedicine is it doesn't work. The name tells you that. If it worked, it would just be called medicine. And this, I thought, as I was on the train going back to my home, I thought, well, that's a really interesting observation, because what he's essentially saying is that innovations that are adopted and mobilized in everyday practice really disappear. They cease to be things that we take notice of. They've been routinely incorporated, and they've become just part of the way that we do things around here. So when we talk about normalization, that's what we mean. We mean that things kind of disappear from view. They just become one of the routines that we mobilize. And all of you who teach will have been through the kind of routine incorporation of Zoom or Teams in teaching. And that's just become part of the way that we do things. A lot of us just do that. That's how we teach now in the time of COVID. But normalisation is only one of many possible outcomes of an implementation process. And in NPT, we kind of are able to track the kind of core mechanisms that drive those processes. So if we're looking at how people enact an implementation project and an intervention, that middle meso level diagram that I just drew your attention to, we can see there are four main mechanisms. There's sense making or building coherence, there's cognitive participation, there's collective action, and there's reflexive monitoring, in which we kind of think through the work that we're doing to make something happen, the work that we're doing to join in with something or not, the work that we're doing to enact an intervention in its context, and the work that we do to monitor that work and reconfigure our practices accordingly. This is a very simple model that conceals enormous complexity. Some of these processes are recursive, some of them are transformational, some of them are causal. And we discover how they're working out when we do ethnographic research into innovation practices. So let's have a think about an example. Again, this is anonymized and it's composite. It's not a specific individual study. It's a composite of several. And we have this problem, telepsychiatry. It seems like a great way of doing telemedicine. But here's the thing. In the work that we looked at, there were some fundamentally wrong assumptions made about how doctors and nurses and patients interacted. Telemedicine consults did not duplicate existing, well-established and completely normalized ways of doctors and patient interacting. And when people discovered that, they started to question the legitimacy of telemedicine systems as a way of managing mental health problems. And they discovered that the software that they were using was difficult to use. It lacked interactional workability. And as that happened, they lost confidence in the process of teleconsulting. And they began to discover that they needed a whole new body of skills. And there's a cascade of events going on here that undermine it, that lead to them thinking, actually, this isn't worthwhile, monitoring their practice and saying, I don't know, this just isn't working for us. And we can't change it. We can't reconfigure the teleconsulting service. And you know what? In one of these studies, the telepsychiatry service died after 11 consultations. Everybody just gave up. They could not do the work. If implementation is about doing the work, you must actually be able to do it. And so wrong assumptions were big here. Wrong assumptions about what the consultation actually does and how it's organized and how it can be translated from a three-dimensional space into a two-dimensional space were just wrong. We find increasingly that participatory design is a hugely effective yet rare way of solving this problem. Actually getting the range of interests and views of actual users of an intervention is just vital. So let's think about another set of studies about genetic screening in general practice. So we have a set of genetic screening tools. And again, some wrong assumptions about how they will work with patients. And here again, we have a crisis of legitimacy. So did those GPs think that genetic screening was the right kind of work to do in the consultation. No, they didn't actually think it was GP work. They felt it was work that belonged to somebody else. And not just that, they felt that patients and families wouldn't want to embark on complex genetic counselling in primary care. They didn't see that that was the right place to do this work, and they didn't believe it was that they were the right people to do it. Part of that is about the way in which using screening tools can significantly extend consultation length. So it's about the workflow. It's about how adding new tasks extends workflow and disrupts practices. They also felt, as people often do, that they didn't have the skills to make the most of the screening process themselves. And they didn't feel that they had the time and resources to do it for what were sometimes relatively rare genetic disorders. And in the end, they praised it. They said, these kinds of practices are not an efficient use of GP time. So again, we have a cascade of events, but this was characterized by a couple of policymakers who I spoke to about these studies as professional resistance. I quite like to get the idea of professional resistance out of people's heads, because it's always more complicated than that. Health professionals and patients have this dynamic and chaotic environment that they're working in. They're very, very sensitive to new work that might not fit well with what they believe they're there to do, and with what they've actually learned to do. So when you introduce a new kind of an innovation into practice, you actually disturb everything else. It has to be able to be integrated into practice, and it has to not disrupt other workflow. It's astonishing how little thought is given to workflow by intervention designers. And here's a nursing example about guideline implementation around infection prevention and control. And this is a series of really great studies, one of which I was a co-investigator on. Again, we have a problem of specification that is about wrong assumptions, not about what nurses do, but actually about their workflow and workload. We discover that facilitators of guidelines, people who are put in to help people implement the guideline, actually really never had time to do it. And importantly, they had no leverage over the organisation of care. So they could counsel and advise and influence, but they couldn't say, no, you have to do that. Or more importantly, you have to let your nurses do this. The workability, the interactional workability of the guideline was a problem because it added very significantly to administrative load. It added a new body of work around recording and verification. And it wasn't well supported by management. And you know, nurses came to believe that the guideline was a paper exercise that had no value. And they couldn't change the way it was used. And in the different contexts that I saw this at work, in fact, they couldn't change anything. And so they just kind of drifted away and distanced themselves from that work. So implementation projects stand and fall on workability and integration of the intervention components in the context in which they're used. And I guess the thing that I want to say is how people can work together to operationalize a complex intervention is it depends on the kind of wiggle room that people have. And wiggle room is a very kind of complex sociological concept, as I think you'll appreciate. But it's about the plasticity or malleability of an intervention, how you can change it in practice to achieve its ends, and the elasticity or receptiveness of contexts in which you do these things. They come together to create wiggle room in which you can actually implement something. Obviously, the concept of wiggle room would be much more sociologically attractive if it was a French word. Okay, my final example is about dementia care navigators in primary care. And we need dementia care navigators because actually for many people, it's impossible to work out where to get help. And healthcare systems are often quite good at moving people around and assessing them, but sometimes not so good at actually providing routine, sensible, material assistance to them. Well, once again, we've got some wrong assumptions here about the design of the intervention. It assumed that actually it was possible to navigate people through systems that were actually designed to exclude people. It was assumed that navigation would be a way of connecting people to services that were not good at attracting users. In fact, the problem that the services had was that they had too many potential users and they were working to exclude them. So they were actually becoming quite inhospitable to potential patients and caregivers. Once again, there were issues about legitimacy. The care navigators realized very quickly that they might not be the right people to link people to services. And they discovered very quickly that many participants in this process didn't think that care navigation was the way to solve these problems. Later, we found that participants didn't necessarily trust navigator tools. They didn't necessarily believe that these were guiding them in the right direction. And my goodness, they discovered very quickly that navigators weren't supported or resourced. And as those things cascaded, people came away to think, well, actually, navigator work isn't that worthwhile, because we can't change the way that navigators are deployed, and we can't actually reshape services so that they're receptive to the work of navigators. So in all of these cases, we have what's effectively a cascade of complex problems that lead to people saying, this isn't worthwhile. We have failure to renegotiate relationships, rules, and resources, and actually failure to think through how implementation projects and innovations can change the identity, the role of the people who are working in them. So what does NPT tell us about failure to launch? Can we predict what might go wrong? Well, I say yes, we can, and we can think about it again in these three ways. Let's focus on the actions of participants at work. There are lots of ways of testing an intervention and its qualities, and there are lots of big models, often economic models, that help us think about how work is contextualized. Economic models and big workforce models as well. But here's the thing, what people do and how they negotiate their actions become absolutely crucial. There are about 400 NPT studies now, and we know that they tell us a significant amount about this particular kind of way of problematizing implementation processes. I've been astonished at the reception of NPT. Elizabeth Murray, who was is professor of general practice at University College London, led a group of us to think about trial evaluation and trial design, and develop this really kind of sensible, useful model that sort of separates the intervention from the trial and says we need to analyze both the trial processes and the intervention that is being examined using NPT. And the question that we're asking is the intervention likely to normalize? Is the intervention likely to be one in which the trial itself is feasible? We've seen this used, and we've seen people not do trials because of it. So NPT supports evaluation, but it can also be a trial killer. It can also say, no, we're not going to do this. It's not going to work. And to help us decide about that, Tracy Finch and Tim Rapley and colleagues, and I played a very minor role in this because I'm enumerate and not a great not a great instrument designer, developed this fantastic Nomad questionnaire, now available in I think 8 languages, that helps us to predict implementability and to measure the primary constructs, the implementation core. And it's an absolutely fantastic tool, and we're seeing it used very widely in very different circumstances. So I've just seen a paper that kind of tried to measure implementation processes in supply chain management using this this instrument. It is fantastic. If you're interested in NPT, it's well worth looking at. It's completely free, and it's available at www.normalisationprocess.org. I'm going to follow this up with further advertisements over time. So that's where I am in terms of talking about failure to launch and introducing a couple of tools that help us think through and measure NPT constructs in ways that might help us detect some of those problems as they come on stream and before they come on stream. So because much of my work is funded by the British government, I'm required to say that nothing that they've funded is their fault, and they're not to blame for anything that I've suggested that you might do. So thank you very, very much for your kind attention, and I think I've managed to do that actually in time.
You've done perfectly.
Have I? Wow.
Perfectly. Thank you, Carl.
Because usually I overrun by hours.
You've done very well. We have quite a few questions in the Q&A chat box, Carl. Would you mind if we go through a few of those now?
Oh, let's do that.
Fantastic. First, we have Dr. Tim Olderhartman, who's actually a Dutch GP researcher. So welcome, Tim, from the Netherlands.
Hi.
Yeah, Professor May, thank you so much for your clear presentation in a field that's quite unknown, at least the theory to me. Where do you think that implementation science in general and the NPT specifically will guide us into the future?
That's probably a life's work, but I'll try to unpack it quickly. What NPT helps us to do is to understand at a meso level factors and mechanisms that motivate and shape implementation processes. And implementation processes are ubiquitous. They happen in all fields of human activity. So at that level, NPT is not specific to implementation science. It's a middle range sociological theory of how people change things. Implementation science, I think, is a hugely interesting field. Implementation scientists, I think, are trying to help us to understand how to cross those big translational gaps. That seems to me to be the purpose of implementation science as a field. And those translational gaps don't just exist in healthcare, they exist in education, they exist in criminal justice, they exist across the range of human service professions, where we have people who are producing evidence about what good practice should be, and people who want to alter and change their practices so that they're good. So is that strategic impulse about improvement, and how do we go from everybody saying, oh, it would be a great idea if, I don't know, we didn't kill our patients, to actually a situation where fewer patients get killed? You know, that's the aim, I think, ultimately of implementation science as a field. I often call myself an implementation scientist when I want money, because it kind of sounds romantic and exciting, and it sounds as though we've got an answer. Sometimes we don't have an answer, and sometimes the answer is some years away. And I say again, I go back to those slides I showed at the beginning that were about what's different about research projects that aim to cross the translational gap, and actual implementation processes that happen in the wild. They are very different. So implementation science research and theory in health psychology and sociology and economics can help us understand the dynamics of change. What are the things that drive it? But they may not necessarily tell us actually how to do things. For that, we might need to look at the other sciences that focus on how collaborative work gets done and how collective action is taken.
We have lots of questions rolling in. I might pass to Lauralee for the next question, if your internet is okay, Lauralee.
Yeah, hopefully rural New Zealand for you. We've got a question here from Associate Professor John Mankiewicz from the University of Melbourne. So thanks, Carl. I'm interested in your comments about professional resistance. I'd be really interested in your comments about the perception of this. For example, I'm often told that GPs are too difficult by non-GP specialists or other bodies. So it is not necessarily professional resistance by the profession, but rather the perception of others. Has this been something that you've come across in your work, and where does that fit into normalization process theory?
Okay. Well, of course, GPs can be very difficult. I think that's an established scientific fact.
Careful, Carl. I'll mute you in a second.
Yeah, seriously. Here's the thing. Sometimes people are resistant to change. I'm not saying that no one is resistant to change. Goodness knows I'm resistant to change. But we have to understand that there are different motives for not necessarily wanting to go along with a big change. I've sort of talked about workload and workflow and capacity and integration, because those are really important factors. One of the remarkable features about the mobilization of implementation projects and the mobilization of innovations is that they almost always appear as an addition to what people are doing. I've yet to be part of a program. I mean, I'm a university professor, but I mean, like many people, I'm constantly confronted with innovations that mean that I end up doing quite a lot more work than I was doing before. And as a result of those innovations, I've recently decided to call myself a senior word disposal operative rather than a professor, because my entire work is now organized around processing email. I never see, I hardly do any research and I hardly ever teach students, but I do a lot of emails. So yeah, I'm resisting. I'm part of the resistance. workload reduction models are almost never included in innovation projects, and they're really worth considering. So if you're asking people to do a lot more work in the same amount of time and for the same amount of money, given that we know that in many countries primary care is private practice, not everywhere, but in many countries it is. So people have to think seriously about how they're going to pay their mortgage. You know, these are factors that are often forgotten, and an important part of thinking about innovation and change is how respectful those processes are of the people who are their targets. Often they're not respectful of how people work and live, and it's worth thinking about that. I've done work in a cognate area around burden of treatment, looking at how innovations in care pile work onto patients now that they previously didn't have to do. And again, the question here is about how respectful are we as innovators and implementers and health service researchers and healthcare policy makers of the way in which people actually live their lives at work. Really important. I mean, I don't want to get sort of this to sort of descend into a sermon about human dignity and respectfulness, but actually that's where it comes from. If you're going to say, oh, I want you to do this and it's really good for patients, but it's going to add 4 hours to your working day, you know, and we're not going to support you in that. It's going to work. A great example of this is the introduction of the EPIC electronic health record in North America, which requires physicians to work through multiple screens with their patients. And it's important in North America because it adds to billing. It's about how money gets into the system. So you have to keep these very adequate records. An entire new class of healthcare professional has been created as not just of EPIC, but as the result of these big EHRs. The medical scribe, the person who follows a doctor around a hospital, and the doctor dictates to them what should go on the record. I mean, this isn't so. Unless you've got some way of creating a resource to meet those expectations, which is what's happened in the big hospitals, where the costs can be immediately passed back to the patient through the insurance company, then resistance is a thing.
Thank you, Carl.
I sort of feel that might have over-egged the pudding, but
no. I maybe related to the question is Professor Grant Russell from Monash University in Melbourne. Thank you, Carl. It seems that many of the examples of failure to launch stem from a lack of understanding of the context and motivations and characteristics of the actors. Do you have any insights as to how this mapping type stage might be best and most appropriately conducted?
I think experience-based co-design is a great way to sort of get into that, to have really good participatory design work right from the get-go, right from the stage of thinking about what we're going to do. Often users are brought in once the intervention has essentially been designed to sort of tweak it so that it might fit a bit better. There are some really good examples now of how participation can help people think through what interventions and services should really look like. I mean, Victoria Palmer's work at Melbourne, I think, is a really good example of that. I don't want to, although I've talked a lot, because I've been talking about failure to launch rather than death in middle age. So wrong assumptions about what people do, and lack of thought about design and users is a powerful part of what goes wrong at failure to launch. Other things can go badly wrong later in the life cycle of innovations, but I'm a huge kind of supporter of the idea of proper participatory co-design, not just around innovations, but around services more generally.
And Carl, can I just ask you there? So have you seen NPT used for intervention development? Because I haven't seen that, but have you seen that?
Yes, I have. So a really good example is Elizabeth Murray's HELP Diabetes trial, which was published in well, it's been published everywhere, but and I think John Furler's work on insulin management in primary care. I actually there's a little group of, I mean, so also I'm thinking Meredith Temple Smith and her work on chlamydia screening. So there are a group of Australian researchers who've done a lot of that stuff. It requires, the thing about that sort of design is it requires a big grant that allows you to develop the intervention in that way.
Right.
Not all funders are hospitable to the idea that you're going to spend a year kind of building and designing something that will work. Quite remarkable. And sometimes funders are really reluctant to support that. I fear that there's a generational change required to sort of sort that out.
Lauralee, would you like to ask the next?
Yes, we might have time for one more question, Liz. So a question from Dr. Louise Leverty from the University of Manchester here. So thank you for the interesting talk. Could you comment on how you think events like the pandemic will fit into or be captured within normalization process theory? For example, the pandemic has been credited with the acceleration of the implementation and adoption of digital technologies in healthcare. And so I should love to hear your thoughts on that.
Yeah. I think, well, two things. Yeah, accelerated implementation is a thing. And one of the people out there in Zoom land watching is my colleague Anthony Gilbert, who was doing work about video consultation in physiotherapy and orthopedics, and was doing this really fantastic, deep, discrete choice experiment, qualitative work, and then suddenly he wasn't doing an experimental study, he was helping to implement video consultation across an entire NHS trust. Well, yeah, so NPT was a bit useful for him, and there's a paper in BMJ Quality Improvement, I think it is, that he and his colleagues describe what they did. I think the processes that we look at around implementation are often long because they require in healthcare extensive evaluation. But actually, nobody said we really need to do a few more systematic reviews before we protect our doctors from infection. They just said, oh no, look, let's not introduce super spreaders to healthcare facilities. Let's keep them at home. And that sort of worked, didn't it? So what would be interesting, I mean, big changes happen all the time. And they often happen because people want them to happen rather than because they're a good idea. If you want to, I mean, I could go on at quite length about this, but actually, at the risk of sounding like somebody with narcissistic personality disorder, I have got a video on YouTube about this. That is a seminar that I took where I talked about accelerated implementation for the East of England ARC. I don't like recommending that people watch me on video because I'm just not very good at presenting. But so I did discuss that at quite some length, I guess it would be worth having a look at Anthony's papers, which are very abundant on these sorts of shifts. What is interesting is how much of this will still be there in 5 years' time. That's the thing. So, I mean, you don't have to go far in the UK at the moment to see a tabloid paper saying something like when GPs go back to work, as though like they've never done any work for the last year.
Yeah.
You know, but how people see things. I think the risk is that in primary care, it has turned what was really relational work into transactional work. So now you do your e-consult form in the UK, and you've no idea who's going to read it or who's going to get in touch with you.
Mm.
And that person probably won't know very much about you. So that sort of knowing the patient has disappeared. But for the patient, knowing the doctor or knowing the nurse has also disappeared.
Mm.
So it has changed the nature of the interaction very, very profoundly.
Mm.
So there's some stuff there about what people will want to keep, and what healthcare professionals and health system providers and patients and caregivers will want to keep may not be the same things.
Yeah. Thank you, Carl. We've come to the end of the session now. We're sorry we couldn't get to all of the questions. There's some really great questions there, Carl. We might give those to you in email format, perhaps. But
well, I was going to say, feel free to email. You know, if we were at a real conference or seminar, we'd all go. Well, here we would be going for coffee. There we would be going to a hostelry of some kind, and talking about this. And that's what the downside of big conference presentations like this. But so get in touch if you want to. Be great to hear from you.
I can vouch that you're a very approachable person, Carl, on Twitter and everywhere. So we really thank you for being with us today.
Thank you for the invitation, and thanks for the opportunity. Thanks everyone for your interest in our work.
It was such an insightful presentation. I'm sure members and other people present really appreciated it. And before we leave, I just wanted to remind people about the membership, to go visit our website, but also wanted to just say that we've got an annual research conference, an online conference that's coming up on the 12th and 13th of August. Call for abstracts are open, so please everyone just submit your work. We're really keen to hear from you and looking forward to seeing you online then.
Thanks everyone. Carl, I'm going to press the end button, and it always ends a webinar very quickly and abruptly and boots us all out. So
okay, it's been great talking to you all. Bye.
We really appreciate it. Thanks, Carl.
Bye bye.
See you soon. Bye.
I hope so.